Exercise really is a treatment for many of the side effects that come from cancer, whether that's fatigue, sarcopenia, aka muscle loss, really accelerates from cancer treatments, as well as the lifestyle changes and behavior changes. But we really don't prescribe exercise ahead of the game to attenuate or slow down or avoid those common side effects. And I think that's really a missed opportunity.
I have an incredible guest with me today. Sami, guys, is one of, I think, the world's leading experts on exercise and cancer. She has been on the forefront of making sure that we as a community know the importance of exercise, how to exercise. She has built incredible content that I highly recommend you watch. And she has programs as well. Sami, thank you for joining us on the show.
Thank you, Samara. So good to see you, hear you, connect with you. I know like we kind of paths crossing in the wind. And I will say I appreciate your compliment. I definitely know I'm not the forefront researcher, but I've always been really excited about implementation, the way that you are excited about implementation. And so I kind of hang my feather in my hat there of like, let's get it done. Let's quit talking about it. Let's just do it. So I'm excited to be here because you're a do it girl. So perfect.
Thank you. I appreciate it. All right, let's start, okay? I have, thousands of questions for you. And we're going to start with why you believe exercise is effectively a treatment.
Definitely. I would say, we always have to be a little careful who we're talking to. And like, there's this, I wish exercise was the only treatment. We do have certain nuances there, but really the big thing that I think we need people to understand is that exercise really is a treatment for many of the side effects that come from cancer, whether that's fatigue, whether that's that physical deterioration that we see, sarcopenia, aka muscle loss, really accelerates from cancer treatments, as well as the lifestyle changes and behavior changes. So I think that often we know that if there's a side effect, and especially if we have a predictable side effect in oncology, we're going to make a prescription, typically of medicine, right? Or sometimes dietary, but we really don't prescribe exercise ahead of the game to attenuate or slow down or avoid those common side effects. And I think that's really a missed opportunity. It's changing, but not really at the pace that our population that has the diagnosis really deserves and could benefit from.
Before we go a little bit down this rabbit hole, can you tell us about how you picked up an exercise?
Oh, so random, but so cool. I really ended up in this space by accident, and I have always loved exercise and function. I just am fascinated with how the body moves and the, physiologic structures of the body, like connective tissues and cells and all of that. But coming out of college in like the late 90s, I know I'm dating myself, but I've been doing this almost 23 years. And I will openly admit, like, I didn't want to do physical therapy. I didn't want to do sports medicine. So I didn't really know what I wanted to do. But I actually started trying to kind of navigate post college life, found a job as a personal trainer and was working at a big gym. And I had developed relationships with our membership team. They introduced me to a woman who had just joined, and you get personal training sessions. And her name was Kim. And I called Kim and I was like, "Hi, I'm Sami. I'm your trainer. And tell me about you." And Kim, 22 and a half years ago, had just completed treatment and some reconstruction for triple negative breast cancer. She had all of the side effects, lymphedema, the cognition changes. She had cardiotoxicity. She had weight changes, sleep disruption, you name it. And at the time I was like, is this normal? Because this seems like a lot. But I wrote everything down because there was really not a good Google search. And her last question was, "Do you think you could help me?" And my answer was, yes. And this was 2003. We had no data on really even safety, much less efficacy. By the way, Kim is still a good friend of mine. We text regularly. She's now a grandma and, still, back in stays in her routine. But I think she opened my eyes to the possibility, and it was a profession I never left. People said, "Well, would you choose a new profession?" I said, "Listen, if cancer goes away, sure." But here we are. And so that's just the space that I've been in. And I'm just endlessly curious. and excited to see where we've come, but disappointed that we're not there faster because I think we really could pick up some momentum here. So that's how I ended up here all those years ago and still here. Still love what I do.
All right, look at that. You do not look like you graduated college from the 90s, okay? Just saying.
Yeah, I know. I'm peeking around the corner to 50, but it's, little, it's almost there. But that's okay. I tell people, what's your secret? And I say lifestyle, like genetics, but lifestyle is part of it. Yeah.
One of the things that happened, I think this year, if I'm not mistaken, at ASCO was, I think one of the main headlines was new data that shows the real efficacy of exercise. Can you
Yeah.
talk about that? Can you talk about what that showed us? What did it
Yes.
confirm?
So this was the challenge trial. So the challenge trial has been like tremendously popular. It was the first randomized control trial that looked at the power of exercise really to improve overall survival. So a couple of kind of key things to think about for audience when we think about, you know, research. Randomized control trial is, group A, group B, right? Like it just compared two populations with obviously very different recommendations, although they weren't tremendously different in one capacity, which was the power of empowerment and the power of awareness of exercise, colorectal cancer, specifically this group. So, what's cool about this intervention was that it educated everyone of the importance of exercise after they had completed their treatment for colorectal cancer, stages 1 through 3, to my knowledge. And that was like the base. And I think that's really great because that's even something that's new. But really where we started to get even more powerful was then the second group was given supervised guidance and recommendations on exercise. And so the structured group had exercise professionals trained in cancer and also had a health coaching kind of mentality. So patients could select the type of exercise that they wanted. They were guided to meet exercise recommendations. And really, the biggest piece was that the structured exercise group had a 28% lower risk of cancer recurrence or developing a new primary. The overall survival and disease free survival was kind of on track close with each other, like the high 70s compared to 80. But like those numbers do matter, right? Like, 5 to 6%. It matters for the 5 to 6%. But what was powerful was that we were really using it in comparisons against, like what is the long-term survival when it comes to traditional treatments? And really exercise kind of surpassed by a nudge. That was pretty cool. So my idea is like, well, and let's just put them together. But I think what's difficult is that challenge was supervised exercise, a certain type of professional, and a group that sometimes is hard for most of our population to access. So now the next lens of this is, all right, how do we take this information and vastly expand it, right, to everybody? But that was the first randomized control trial of its kind and shows us now, okay, we can duplicate this. And I think that's what's key now is how do we move forward?
Sami, just so that I understand this right, the challenge trial takes colorectal cancer patients across a couple of stages.
Correct.
Your control arm, base arm, is traditional treatment, and put that in quotes, whatever standard of care is. And then the
Mhm.
intervention arm is standard of care plus a specific exercise program under supervision.
So both groups came off treatment, but the group that was in the standard arm just received basic education. I have to look at my notes to make sure that I'm right on that, right? So they just got education of the importance of exercise to improve survival. Group 2 had the health coach that was an
Uh,
exercise professional. So there's the health coaching is quite popular. We have some really good reimbursement for health coaching right now, but the health coach drove that intervention forward. Also, kind of kept people going and excited. Interestingly, and I think this is kind of phenomenal, but also like, how do we duplicate the length of the study was 3 years, right? So
yeah.
the question is, do we need 3 years? The answer is, well, we need people to exercise for 3 years. It doesn't matter how we get them there. But I
Uh,
think that, what we really wanted to show was in an extended period of time, a lot of exercise studies are very short. They're 12 weeks, 12 months. That's not really enough data and enough length of time. So that was the key piece. So no treatment. We still do treatment. But what I think people are starting to think about with challenge is it treatment or? And the answer is no, right? Will we get there? I don't know. In prostate cancer, like low stage, early stage prostate cancer, we don't do the hormone interventions that the way we do in early stage hormone positive breast cancer. We actually really emphasize lifestyle. So I find that to be quite interesting. But you have been through this experience. If someone gives you A or B, that's a hard choice. I mean, most people are like, I want A and B. Like, give me both. And so, how do we study when we're looking at humans and we might be taking away something that we know works when we're trying to figure out what else could work? And I think that's sort of a real challenge of human trials. But I think the lessons are really good. And I think the lessons are like, hey, this really does make a difference. And that was what was powerful.
Thank you for that. I really appreciate that. I'm going to move to chapter 2 of our episode.
Great.
I really want to talk about specific side effects and symptoms and how exercise can help you being a patient, a survivor, navigate that. So I
Great.
have a list of my favorite side effects. Favorite is fun that you guys, but my favorite one. And then I'm sure you'll have a few more to add. You ready?
There's always side effects. Yes, let's do it. It's like I feel like we're on Jeopardy.
I
Side
know.
effects, please. Side effects for 100.
All right.
No, it's
You ready? Fatigue.
oh yeah, right. Number one.
The eye roll. Oh, that's precious. Oh.
And again, like fatigue is one of these ones that it's like, I think we just sort of throw everything into fatigue, but it's like, well, what kind of fatigue? Is it physical fatigue? Is it emotional fatigue? Are you in treatment and you're showing up for radiation every day? Are you managing the world of life? You've got aging parents and busy kids. But let's just speak really physiologically. When we think about fatigue, one of the key reasons that we have fatigue and fatigue that doesn't resolve in cancer is the natural part of aging is this process called sarcopenia, right? So sarcopenia means loss of muscle. We as women start losing muscle at the age of 30. So depending on when you were diagnosed, depends on where you are in that. And then it doesn't start till 50. This is also a whole other reason of metabolism and why men don't put on weight the way women do, but that's a conversation for another day. But we all experience sarcopenia. As adults, it's about a half a pound of muscle per year at those age ranges. When we go into cancer treatments, when our physical activity changes, when our dietary patterns change, when we have medications or treatments that slow down how my body tissues can recover and repair, we see an acceleration of muscle loss. This is also really vastly accelerated when we give things like steroids, when we put people into menopause, sort of this kind of conglomerate of things. Physiological fatigue, loss of muscle, number one recommendation for people, of course, reduce inactivity, because the more we sit, the more our muscles just kind of drop off, fall away, because they're not active and the body is trying to repair from all that other stuff. But if people say, well, what's the number one type of exercise to do? It's strength training, because aerobic and walking will get you feeling okay in the moment, but it doesn't build the muscle back to build you a bigger engine. And cancer takes away your engine, and that contributes to your emotional engine as well. So when you think fatigue, yes, reduce your time on your tush, but second, just do strength training. It doesn't have to be weights. It could be body weight, but definitely strength training.
Okay. What is strength training?
Oh, great question. So anything that overloads the muscle to create tension and fatigue on the muscle. So as an example, if you think about sit to stand, AKA squat, if you get off your chair, if you get off the toilet, you go from, any form of like in your car seated to a standing position, you are actually using the thigh muscles to contract and drive your body forward. If we do that for time, repetition, and load, meaning I might do 10 and my thighs are burning, that is strength training. We want to overload muscles. It is really much more about the muscles that connect our joints together, thinking about the arms, the legs, the back, the chest, than really increasing our heart rate. So that's what I want people to kind of think about. I think, yes, my purists will be like, but Sami, strength training increases your heart rate. Yes, but that's not the goal. The goal of a walk is your heart rate, feel breathy. The goal of strength training is increase the tension on your muscles, feel the burn. That's the difference.
Second side effect, symptom,
Okay. Bring it.
joint pain.
Great. We were just sort of alluding to that. Oh, yeah, joint pain. So, a couple things. Joint pain is going to come from loss of strength training, right? Or loss of muscle, because you of course strength training. But here's the thing: the joints, actually, the connective tissue just honestly becomes stiff. It loses its natural form of fluid. If you go into menopause, your joints are going to feel a lot, more creaky. Also, when we don't use them, our joints just don't have that sort of natural lubrication in them. It actually, we require using them. I give the example, if you have a bike that's been sitting in your garage for a while and you start to, try to make that chain move, it doesn't, the lubrication has to go back through. So that's part of with the joints. So the recommendation I have for people is take the load off. So if you're looking at knees, maybe your knees hurt you, sit down on a chair, on your sofa if you want to, but chair is better because it's firm. And just think about flexing and extending the leg from the knee. So you just pick your foot up off the ground slightly, kick that leg out to straight, bring the foot back down. You can set it down between reps if you want to, but just that knee flexion and extension will bring that synovial fluid, AKA joint lubrication, back. And that's actually going to really help you. Over time, some people say, well, impact might bother me. You just have to take that individually. But I think just getting your joints active, going through range of motion is first and foremost one of the best things that you can do. Yoga, Tai Chi, anything that just sort of makes you go through movement patterns in a light way can be very beneficial.
I want to double click on a specific type of joint pain.
Yeah.
So I have a lot of patients, breast cancer, that are on hormone blockers, some form of
Oh,
hormone
yeah.
therapy.
Uh-huh.
And one of my favorite side effects, and there are many, is joint pain. So let's say I am newly starting hormone therapy. And there are a couple of classes of medications in here, but given the multiple classes of medications, if I am starting to grapple with side effects of
Hmm.
joint, where do I start?
Same thing. It's going to be the same thing because the reason you're going to have the joint pain from those medications is those medications block estradiol, the main type of estrogen, right? So right now, menopause is so popular. Cancer-related menopause is a little less popular because it's just a little bit, more scary to talk about. Not for me, but general population, yes. But we like to throw estrogen in this big bucket. But estradiol, the specific type of estrogen that we are shutting down in your body because of hormone-positive breast cancer, the job of that estrogen also has a lot to do with creating some nutritional value for your joints and also in combination with another pairing of hormone progesterone. So those pairings helps your joints stretch as well as also remain tense. So because we've like broke that pairing, we've sort of created this divorce between these, or we've shut them both down. Your joints are like, what am I doing? Like, give me my, like, are you helping me to stay strong or are you trying to like loosen me up? So there's sort of a flip side of it. The joint pain isn't always because the joints are tight. Sometimes it's because they don't have enough support. So honestly, with people, if you're concerned about it, I would really seek out a referral for like physical therapy because that's a opportunity that someone can just evaluate. Like, do you have like movement dysfunction? Do you have orthopedic challenges? Those kinds of things. But the two joints that we see the most challenge with after breast cancer are actually in our feet, plantar fasciitis, and actually our shoulders, sort of all of these versions of rotator cuff. And not that everybody can see me, but I'm air quoting rotator cuff because it's not all rotator cuff, right? It's a lot of just dysfunction in the joint. So it's actually not our knees and our hips. Most of those are related to less quad strength, the muscles of the thigh, a lot of weight gain in the middle. They're more functional from a hormone perspective. Two challenges that we're seeing are again in the feet and the shoulders. And part of this is just because of that imbalance now of hormones and a bit of that overusage of connective tissue that hasn't had to work that hard. So it's much different than we originally thought when it used to always be in our knees and our hips. Typically that comes from before, but is accelerated from the medication.
I didn't know
Same
that.
recommendations. Yeah.
So if I have plantar, I can't say a word. Plantar.
Fasciitis.
Thank you.
Yeah.
What I do?
So interestingly, the biggest thing is you need to make sure that you actually think about stretching out the connective tissue in your feet. So the connective, like if you think about like the feet, so imagine your feet and wherever you are, kind of think about squeezing like your toes into your heels, like you're scrunching. We need to think about being able to stretch those muscles out, spread out those feet. So that's actually if you do yoga and they talk about like spread out your feet, place, tension in your big toe all the way across to your small toe. Great. That's one of the number one things to do is spend that time barefoot and try to stretch out our feet. Also, if we can get on something like a tennis ball, a golf ball, a lacrosse ball, a ball that your dog plays with, and like really kind of rub out that connective tissue, that also really helps. But here's an interesting thing. When we sleep, our feet actually, our toes drop. So think about how your foot position when you sleep, right? There's a lot of popularity, and I talk about this in my lifestyle programs for weighted blankets. Well, if you have a weighted blanket on your feet, you're actually creating extra tension. So, there's all of these things we almost have to unravel. But sometimes it's like kind of taking a look at some of the lifestyle pieces. But that's one of the biggest things to do is just really get those tissues stretched out, stretch out your calves a little bit, spend time barefoot. It really does make a big difference.
Okay.
I know. It's all one big ball of yarn, if you think about it.
Okay. Next one. Ready?
Yes.
Okay. Neuropathy.
These like all just sort of fit together. It's really interesting. Not they all, but they do. They fit together. So neuropathy, thinking about that loss of nerve sensation. I will say, interestingly, just a small kind of step away from exercise, new evidence in neuropathy, which is something I've been really speculating on for probably 10 years, is understanding dietary patterns related to nerves. Because we know that there's diabetic neuropathy, and we
Yes.
see a much more highly processed dietary pattern, both in the States and across the globe. And we actually are starting to see that, for our nerves, giving them some repair, we need to be in consideration if we're pre-diabetic or we might have, type 2 diabetes, because those are dietary indications. But to help those nerves recover, we need to actually create stimulation. So a couple of things. There are any exercises that you can do that stimulate the foot, the ankle, the calf, the lower part of the leg, all work. Anything that you can do for balance, all is going to help. However, we want those nerves to wake up. And so we need to create sensation. So one of the things, and I've done this through several of the programs that I've worked at in health systems, patient education, giving people tool to kind of what can they do to create nerve sensation. So we suggest taking like a washcloth that's kind of scrubby or like a loofah and really rubbing that across the skin of your fingertips or your feet, depending on where that neuropathy is, because you're telling those nerves to wake up. It is time to recover. And we need to create that communication again. So a lot of times we let, neuropathy happens from our treatments, and there's a recovery. We say, well, what you don't get back in a year, you don't get back. Well, we got to work at it. Unfortunately, we have to pull these manual levers. So a great manual lever to do is to stimulate the nerves to wake up. So again, rubbing a washcloth or something kind of rough on your skin really works. In your feet, if you don't have plantar fasciitis, if you pick up that washcloth or that loofah, again, you're making those nerves get back to doing their job. They've taken extended vacation. It's
Hmm.
time for them to come back and help you. So I think those are really key things to think about when we give people simple strategies.
Amazing.
It's
Okay.
not comfortable, by the way. It can be very uncomfortable, but even if you do it for 10, 15 seconds, it does help.
Amazing. Next one. Lymphedema.
Well, so two sides of lymphedema, right? So risk reduction versus management. So this is actually something that's changed so much in my career is risk reduction recommendations. So if you think about this, muscle is actually a pump for lymphatic fluid systemically. So one of the recommendations that we really have for people is even if we're getting ready to undergo treatment and or surgery for breast cancer, that we start an early exercise program, both for range of motion, but also let's get those muscles active
Mhm.
early. Because if the muscles are active early, we know they're going to have to take a break, either because we need recovery time from surgeries or we have a lot of skin damage from radiation or combination, right? And that's one of the challenges in breast cancer. So we want to do strength training early and
Yes.
we want to really focus on range of motion and we want to come back as quick as we can. So the prevention strategies have a lot to do with strength training. They also
Mm,
have a lot to do with weight management.
mm,
Because again, if we're gaining a lot of weight, especially that fat tissue, doesn't matter where you put it on, we're slowing down that lymphatic fluid. Now, weight gain after breast cancer, it happens. Most people, like even if they lose or they don't gain weight, if they lose muscle, they gain fat. So do not beat yourself up. Just know that we want to be thoughtful that if that weight is 3, 4, 5 pounds, which is really common, it is life. It is what happens after that experience. But if it's like 10, we need to be very thoughtful on can we do lifestyle a little bit different? And I think that's really a key piece. But those lower weight numbers are super common. So I tell people, don't worry about it, but move those muscles, make them work. If we have active lymphedema, it's going to be very individual. And so
mhm,
this is when we really want to make sure
mm.
we go to a certified lymphedema therapist. We have that arm evaluated. We have good measurements to understand how significant, how severe is that lymphedema. I tell people the only way to reverse lymphedema that we know of to date is to catch it early. So if
Mm,
you're at all nervous about lymphedema and you're very concerned, a lot of programs have assessment devices, specifically the SOZO that assess preclinical lymphedema. Do that. Number one. Number two, measure your own arm early so that you know in that day of, is my arm bigger? And so sometimes we need to educate ourselves because I don't know if I can get into the lymphedema therapist. So we do a lot of self education and we've actually seen benefits around anxiety in lymphedema. But secondly, and lastly, is if you are concerned about lymphedema and you're like, my arm just feels different, persist, persist, persist to get the appointment. Don't let them blow you off. And I think that's one thing that we've gotten better about, but we're just in a lot of change with healthcare. And sometimes we have to get a little bit, stronger shoulders to push and validate the importance of it. Part of it is just getting good information and making sure that we're not making things worse. But if you have active lymphedema, we need to start there and then they can help you get back to an exercise program. And I think that's really a key and a partnership I've always had in my career is with lymphedema therapists.
Amazing. Okay. Super, super helpful. I think we're going
Excellent.
through Samira's symptom management list at this point, by the way.
Great. I love it. Let's do it.
All right. I have two more. Uh, Weakness.
Ugh, dig deeper. Tell me more. What kind of weakness?
So there's fatigue, right? Which for me feels different than I just feel weak, right? I'm
Yeah,
doing all the exercise, I am sleeping, I'm eating right.
everything is great. I'm doing it all.
Yeah.
So another thing, and this is really specific to so broadly, this is not an answer, but for when we look at hormone positive breast cancer specifically, and we look at menopause, one of the things that we understand is that estradiol, as we have learned, has many, many jobs. I refer to estradiol as the queen bee. And I think all of us can be like, ooh, I've had a queen bee or I am the queen bee. When the queen bee stops working on the hive falls apart because the queen bee has done all these jobs. So when there's this divorce of the body to estradiol, then the jobs of the queen bee are now gone. We have to do the manual levers. One of those has to do a lot with our mitochondria, how our cells, which we have trillions of cells, an estimated 28 to 30 trillion cells, how our cells actually take in food for fuel. Okay. And this is through the housing system of the cells, the mitochondria. The mitochondria is sort of the power plant for all the cells. How the cells use fuel changes. no estradiol, I don't get that mitochondrial response. So one of the things about weakness is we think that our body just isn't getting as much of the fuel into the cells. And so the muscles can't contract the same way. I also really have speculated for years when I was really working in like the gym setting and I'd have people come in. I didn't think they could actually have like as much peak output physically after cancer. And everyone was like, oh no, that's not a thing. And it's not muscle. It's just like the output is different. And we also know that our estradiol also helps the blood vessel vascularity. So our blood vessels aren't as um, not vascularity, more mobility, sorry, blood vessel mobility. So our blood vessels stiffen up a little bit. Well, if your blood vessels are stiffening, your heart has to pump harder to kind of get through that lane. So there's all of these things on that. So that's one thing. But general weakness, largely for most individuals, is just loss of pure strength muscle, not aerobic muscle, strength muscle, type 2 fast twitch strength muscle. That's typically the main one. And we need to tweak our workouts to fit where we are now. And that's sometimes annoying for people, as is me. Like, really?
Okay, I'm right there. Okay, last one. Chemo brain.
So I've been continuing to call people or call this, I've changed chemo brain to menopause brain in all the, so there's a couple of things of chemo brain. If we think about memory, you know, focus, all of those pieces from an exercise perspective, I'm going to give you a really simple but odd answer, which is I think often when we're struggling with the side effects of our brain not working the same, I'm just like, I can't multitask the same way, et cetera. There's a lot of good chemo brain strategies that come out, and I hear it a lot from my speech language pathology teams, et cetera. But from an exercise perspective, one of the tools I've really given people is finding an exercise program to follow that you can almost automate most of the main pieces. So as an example, getting online and like following a YouTube creator or showing up at a class where all you have to do is walk your butt in the door. They tell you what to do. They give you music. They give you reps. They hand you weights. Like those key pieces are so useful because you don't have to think, do. You could just, all you have to do is show up. So when I think about chemo brain, we know exercise is going to be helpful. We don't really know the types of exercise, to be honest. There's value in many types of exercise. And my yogis will argue with me, well, there's yoga data. There is, but there's data in resistance. There's data in aerobic. There's data in HIIT. Do the one that you like that also fits your goals, but automate it. That's a really big success strategy, I think, to be able to get it done. So whatever you can find, again, class type thing, you can't afford that or you don't have access. There's so much content that's out there. We just put out a new 6-week on-demand workout through our program because that's what I wanted people to understand is I just have to show up and push play. I can do it at 8 a.m. or 8 p.m. Right. And I think that's one of the biggest things that we don't correlate enough to the chemo brain side is make it easy and automated. It's almost like the habits, right? Like the making it a habit in a different way. But it really does help a lot of people.
So underlying a lot of these things I can do. So if I'm a patient, breast cancer, early or metastatic, I'm dealing with some cluster of the side effects and symptoms we've spoken about. Now, my question becomes a lot of these, the impetus to do it is sitting on me, the patient. Because my oncologist may tell me, hey, you should move, you should exercise. The odds are they haven't pointed me to the right intervention, not because they can't, but because sometimes they don't have the time. You have 10 minutes. Your insurance might not cover it. You may have to do out of pocket. You may not have the financial resources. The list is pretty long. And plus, I am exhausted. So, there's that too. So, amongst all of that, the thing that I've seen kind of consistently come up is the question around safety. I am very activated. Yes, I know I need to exercise. I know I need to walk. I should do the sit stands, but I am actually kind of nervous that it might hurt me. Is it safe? How do you grapple with that?
All right, I'm going to go to the simplest thing that I just have sort of said across the board at clinical conferences and patient-facing conferences. Listen, if chemo didn't kill you, a squat's not going to. Seriously. I mean, like, we are so worried about, like, oh, should I squat? Like, can I, like, should I pick something up from I'm like, oh my gosh, do I carry groceries? Now, truth aside, we put the fear in people. Don't do too much. Like you might hurt yourself. So people individually, and in my 20 plus years of this work, and then we look at clinical trials, adverse events are low, and adverse events typically come from just general musculoskeletal injuries. Like that's going to happen to all of us. We're human, right? Like we're soft tissue kind of put together. So I think the biggest thing that I tell people is it is unlikely that you are going to hurt yourself if you think about two things. One, don't start where you left off if you're coming back to a program, or don't start with somebody else's program if you've never started exercise. Like start at a tempo that makes sense for where you are, first and foremost. Number two is be consistent. Because one of the biggest challenges that we see is like, I worked out for 2 days, then I took 2 weeks off, and then I got to pick back up and go level 3. That's where we see the biggest challenges. I think we're so afraid of hurting ourselves that we stop moving. And if you're really nervous, just start body weight, focus on range of motion, those kinds of things. But even in like where we see the most injuries, which typically come in sort of the historical CrossFit gyms, it wasn't in general movement. It was when people decided that they needed to PR their deadlift. And, I've never deadlifted 300 pounds, so why not today? And that's where we see injuries, right? So from the world of cancer, when we've had our body beat up, you're not starting at that level, but you're better off starting, because if you don't, the number one reason that we have people going to the ER, at least this was probably not the last few years, but for the 10 years before, was low back pain. It wasn't because we had, bone metastasis. It was because people had a bulging disc and then they had to shovel their sidewalk, and they kind of created a much more significant injury. These are injuries that can be so prevented, and they're just functional. So I think that's a lot of our population, is they're just scared. But the way I look at it is like, this can save your life later, and this can help you not fall. This can help you have quality of life. Like this is something you can do. You just need to do. Again, if you didn't die from chemo, you're not going to die from a squat. So off you go. I know.
I love it.
Took me a
All
few
right.
years to say that, but right? Makes sense. Makes
I
sense.
love it. I think you just, I really wish, so Sami, I don't say this very often, but what you just said to me, I wish someone had said that to me 5 years ago. I really wish someone had said that to me.
So we need to say it to more people. And the other thing is this, is that we have this idea that we give you that you just go through cancer and then you magically recover. That has always been the biggest mistake that we do to people, not only physically, but mentally. Like we have to turn the lights of our life back on. And it may look different, but like you're here, you're alive, like let's go. And I think often we don't give you that green light. I also joke, I call cancer the red light district, because we're really good at telling you what not to do, but then we're not really good at telling you what to do. It's true. I know. I say a lot of things. This is what happens when you've been doing the work for as long as I have. You just say it and people are like, oh yeah, that does make sense. But true, right?
Yes. I've never heard
Oh,
that.
let's go.
It's very good. All right.
Another one.
I have 2 questions for you, and those will be our wrap-up questions. You ready?
Great.
Okay.
Let's do it.
So, if I'm a patient, I am ready. I have mentally gotten over the fact that this, a squat's not going to kill me if chemo didn't. I'm dealing with, I don't know, some cluster of side effects. It's phenomenal. Where do I start?
So first and foremost, I think where we get ourselves in trouble is we think we need to do everything at once. Like we need to hit exercise recommendations today. So if you're just getting back, like just starting, I really encourage people to think about exercising only for 10, maybe 15 minutes at a time, and start with every other day. Right. So I do it every other day. You can do any kind of form of exercise that you want, but 10 to 15 minutes every other day in the place that's most convenient for you. Don't worry about perfection. You don't necessarily need supervision to start. Now, I think that that's probably the first thing, because we can just start today. People can get motivated, and I do that. What's difficult is you may not know when your fatigue red light's going to kind of happen. So when we start to kind of go 30 minutes or longer, typically for most people, they hit that fatigue, they're wiped out for the rest of the day. So that's first and foremost. The second thing is prioritize strength training over resistance training. It's not going to feel like as much in the beginning, but it builds your engine, and it's going to build your engine back faster to give you more life in your days. So those are really two key pieces. If you think about where's one thing to start, I'll give you my two favorites. One is find a chair, any chair. Again, firm is better, but couch is really kind of legitimately, if you want to challenge, and just sit, stand, sit, stand, sit, stand. I don't even care if you're watching TV. I prefer if you're not on your phone because then you're looking down. That's not good posture, but sit, stand. Okay. If you want to get sassy with it, you can think about reaching overhead and adding that full body extension. Boom, great. Totally a great exercise. Secondly, another favorite is countertop pushups. Go into your kitchen, put your arms just slightly wider than your shoulders, walk your feet back so you're in a nice straight line, and just do countertop pushups, right? It's super accessible and it's actually full body if you do it right, if you stay in a nice straight line. So I think for people, it's like, I don't know where to start. Do those, do 20 a day of each. Doesn't matter when you get it done. Every other day, call it your exercise, off you go. I think those are two key pieces. Because also people are like, I don't know what to do. Those would be my two favorites.
Okay. That's for someone who is just getting started. What if I just got diagnosed?
Mm-hmm.
Same thing?
Yes, absolutely. However, one of the things is if you have an exercise that you're really like in a routine that you're already doing, if you can continue your routine at a lower intensity, I always encourage people to do it. And maybe you don't have to do it at a lower intensity, but most people have to. I think anytime you're going under stress, your body needs different repair. Well, exercise is a little bit inflammatory. It's a little bit stressful on the body. So sometimes we should back off. Most of the time we should back off actually. So I would just keep going. Now, if you can't keep going, then again, really finding something that might mimic what you love and what you're used to, because that's going to help you with a sense of normalcy would be great. Now, if you kind of been exercising, you've been dabbling, you're like, what should I do? I like yoga, I like aerobic, I like HIIT, or what I like it all. I would again go back to strength because the number one challenge we see is loss of muscle. So the type of exercise that we can do to mitigate that would be my priority, right? So if I can only pick one, it's strength training. Again, every other day, 10 to 15 minutes, start there.
Amazing. Thank you so much, Sami.
You're welcome.
This was, I think I have pages of notes.
Good. You learned some new things yourself. I love that.
Oh yeah, no, definitely. Like there's a list. But my favorite is if chemo didn't kill you, a squat will not. Oh, so good.
We need to make a t-shirt.
We
Like,
really do.
you know,
We really do.
I'm sure when I've said that to like in front of oncology crowds, like on like clinical, they were kind of like, oh yeah, it's like we don't think about this in the big picture of things. Like, can someone exercise? I'm like, but we're gonna just let drugs drip into them. But like, I don't know, it's just a different perspective. And again, I think to the basics, like quality of life for people really boils down to like the things that help us remain independent, getting off the toilet, getting dressed, taking care of the things that are important to us. And so like, I think sometimes we forget that, that like, people need the strength and the endurance and the mental, like, I can do it. I think that's kind of a key piece. So yeah, I need to say that more. Put it on my social.
I love it. Sami, thank you so much for taking the time. I really appreciate it. You are such a joy to speak with, such a powerhouse of knowledge, and I appreciate what you do for the community. Thank you.
Thank you, Samara, for what you're doing for the community and, giving people the roadmaps where these things can be plugged in helps them understand what else exists. And I think that's what people are looking for. They're really looking for these tools to come together in a place like they can manage. And I think that's what's key. So thank you.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Mantacares Inc. or Mantacares' sponsors.